So, good afternoon and good evening. I'm Dr. Ban Hock Tan from the Singapore General Hospital, and I'm very pleased to chair today's Fungal Frontiers webinar. As you know, in previous editions of the webinar, my co-chair has usually been Dr. Sharon Chen from Westmead in Sydney. But unfortunately, today she's indisposed, so I'll have to do this alone. Anyway, I think we do have a good topic, and we anticipate a good discussion. So thank you very much, and I welcome you to this another one in this series of webinars. So these are organized by the Asia Fungal Working Group, which is a working group of ISHAM, as well as the Mycosis Special Interest Group of the Australian Society of ID. So today's case will be presented by Dr. Ren Tong Tong from the National Center of Infectious Diseases here in Singapore. And the literature reviews will be done by Drs. Benjamin Chung, Li Pei Hua, and James Kang, all of whom are ID physicians. For discussion, we are very glad to have with us two well-known infectious disease physicians, Dr. Abby Douglas from Peter Mac in Melbourne, and Dr. Atul Patel, who is from the Vedanta Medical Institute in Ahmedabad, India. So that's the way it will flow. I encourage you all to put your questions in the Q&A. So not in the chat, but in the Q&A. And of course, at the end, there'll be a questionnaire or a survey that you'll be asked to complete. And I do urge you to do this post-event survey. Okay, so let's get on with the webinar. May I call upon Tong Tong from the National Center of ID to present his case, and then we'll take it from there. Tong Tong, please.
Yeah. Hello everyone. Can you hear me? I'm Tong Tong from NCID. So today we will present a case. The name is Fungus in the joints. So this is Madam T, who is 76 years old, Chinese female. She has very good comorbid. She has history of hypertension, hyperlipidemia, internal and amyloidosis, no diabetes, no other medical condition. So regarding her orthopedic history, she had bilateral OA knees and had bilateral total knee replacements done. So the first round is in 2004, in February 2004, and in August 2004, she had right and the left knee TKR done, which does not really have a lot of complication at that time. But about 13, 14 years later, she needs to do revision operation because of the accepted loosening of the joints. So the latest one is left knee revision, total knee replacement in 2018 January. So at that time, the intra-op finding shows some femur and tibial component loose, but there is no path, there is minimal synovitis, and the intra-operation culture O negative. So the operation was mainly done for accepted loosening in 2018 January. But what happened is 2 months later, after left knee revision TKR, she was admitted. So at that time, she presented with left knee swelling. So at that time, the physician examined the patient and found that and did the ultrasound of the left knee, which showed some skin thickening with increased subcutaneous echogenicity, which is possible some inflammatory changes. So at that time, in ultrasound, they also showed a very tiny fluid pocket 1 cm below the inflamed skin. So at that time, the impression from the physician was possible bursitis, which was treated with 2 weeks of antibiotics. So this was the X-ray done at that time, which does not show evidence of implant loosening or periprosthesis fracture. But unfortunately, about another 2 months later, which is about 4 months after left knee revision, total knee replacement, she was presented again with left knee pain and swelling. So this time she was unable to ambulate. So at this moment, the left knee aspiration was done because of the concern of prosthetic joint infection. So at that time, female hemoserous fluid was aspirated, which at that time the synovation test was positive. The knee fluid showed white blood cell 1,644 and the neutrophil about 37%. The fluid culture at this moment grew Candida parasilosis. This was the MIC, which was done at that time. The testable function MIC is 0.75. The fluconazole MIC is 0.5. The left knee X-ray done at that time, which does not show any loosening of the implant or periprosthetic fracture. So this was the just for reference the MICLSI breakpoint of the Candida parasilosis to anidulafungin, caspofungin, fluconazole. In this patient, actually all the Candida parasilosis to anidulafungin and fluconazole all in the sensitive range. So this will lead to our first panel discussion for this patient. In this situation, what is your preferred surgical approach and what antifungal choice you are using for this patient? Thank you.
Thanks, Tong Tong. So maybe we can call upon first Abby and then Atul to.
Thanks for this beautiful case presentation. Obviously really concerning seeing Candida parasilosis in a joint, an artificial joint. I think the first principle would be that I'm very concerned that this patient won't be cured unless we perform aggressive surgical management. So I would be proposing a two-stage revision, assuming that she's fit for the surgery. From an antifungal choice perspective, I guess that's another really interesting kind of quandary in this patient because you know, we do know that echinocandins are probably better for the biofilm component of this. However, you know, the success of echinocandins in Candida parasilosis is always a little bit questionable. The fluconazole is technically susceptible, and so I think that you could argue either way. I think this patient needs at least 6 weeks of antibiotics. Probably on balance, I would go with maybe upfront 2 weeks of echinocandin followed by fluconazole, but I think that could be debated.
Thanks, Abby. Atul, maybe you unmute yourself and then we can have a discussion on what are your views.
Right. So thank you for the nice case. The issue here I can see is like it's a delayed prosthetic joint infection because I mean few months has been passed. So I agree with Dr. Abby that we need to go for a two-stage revision surgery because of the main issue here would be the biofilm formation by any organisms, and we know that parasilosis has a higher tendency to develop a biofilm. So the issue here is that the delayed joint infection, prosthetic joint infection. The second is the organism is having a very high propensity to develop a biofilm. And we know that the treating organisms in a biofilm is very difficult because there are very few antifungal which can penetrate into the biofilm. And we do have only two options over here. One is amphotericin, especially the liposomal amphotericin B, which has got a very good penetrations into the biofilm. And the second option would be echinocandins. And I do agree that, I mean, the echinocandin has a little higher MIC for parasilosis as compared to the other, the Candida species. But we do have, I mean, very good evidence that those patients who has invasive candidiasis because of the parasilosis, and if they have received initial echinocandin-based therapy, the treatment response is same. So there is no significant difference in the treatment of parasilosis who has received echinocandins as compared to azole or the liposomal amphotericin B. So treatment outcome remains the same. So here, I think, I mean, looking at the higher chances of development of the biofilm, and the echinocandins are sensitive. The Caspofungin has MIC 0.75. So I think I'll choose here the echinocandins over fluconazole. The reason is that I need a drug which can penetrate well into the biofilm and can have some the effect on sterilizing biofilm till we get debridement or will do a second revision surgery. The second issue here is that, like, which echinocandins would be best for this situation? Anidulafungin, mica, or Caspo. I mean, generally we do not have a significant difference and no choice. But the only another important theoretical concern here is that if I am planning to give you a higher dose of Caspofungin, say for example 100 to 150 milligrams of Caspofungin per day, because of these significant prosthetic joint infections, and I'm aimed to sterilize the biofilm, then probably I'm little worried or have some concerns about the eagle effect because of the Caspofungin, where there is a paradoxical increase in the growth of paracellosis. That's the only issue. So there is no difference in selections of echinocandins, Caspo, mica, or the Anidula is the same. But the only concern, especially when I'm planning to give higher dosage with Caspo, where eagle effect can leads to the paradoxical increase in the growth of Candida species.
Ben Hock, if I may, I guess one thing to consider is if we are, which we are proposing to do a two-stage, and we're removing the prosthesis and theoretically removing a lot of the biofilm, you know, it may not be quite as important. And we do know that fluconazole gets into the joint fluid really well. So I guess, you know, you could argue either way. I think we probably couldn't go wrong with probably either option, as long as we get good antifungals on board and aggressive surgical management.
Yes, I think a few things have been done well. They took efforts to get cultures, and then the candidate was identified to species level, and then sensitivity testing was done. So I think all the steps have been appropriate. And I'm actually with you, Abby. I think if we are going for a two-stage operation, most of the biofilm should have been removed. And personally, I do think that for paracellosis, I tend to veer towards the azoles, but yeah. Anyway, so the answer to your question, Tong Tong, is that most people think we should go for a two-stage approach. Okay, so now I think we will look at the literature and see what it says with regards to these very things that we have been discussing. So may I invite Pei Hua, who's consultant infectious disease physician, also from the National Center of IT. And she will be followed by Ben Cheng, who is my colleague here, senior consultant in ID at the Singapore General Hospital. So Pei Hua, please. Okay, good, Pei Hua. You can speak up or unmute yourself.
Yes, I'm unmuting. Just hang on. Hi, everyone. Hi, I'm Pei Hua here. So thanks for having me here. So I'll go ahead with the lead review here. Oh, sorry, my slide. Okay. So my part is about background. So looking at the epidemiology of Candida PJI. So most PJI are actually caused by bacteria, as we all know, and most commonly is by Staph aureus and species, whereas like fungal PJIs are either underreported or like it's just a small fraction, which is approximately, like some people would just quote like 1.3%, and then that's why I put it here is 1 to 2% of all PJIs. So for Candida species are the most among all the fungal PJIs, the most isolated one will be the Candida species, and then with Candida albicans as the most prevalent one, followed by the non-albicans species such as like Candida parasilosis, which is our case, and also like Candida glabrata, and followed by Candida tropicalis. And with this paper that I would like to bring everyone to focus on is this I think it's Aurélien Dean, and it is in the big European paper that published on IDSA in 2024. So Deans and friends actually conducted a large retrospective multinational observational cohort study in Europe to evaluate patients diagnosed with Candida-related PJI across 19 hospitals and 7 countries actually from 2010 to 2021. So patients who met European Bone and Joint Infection Society PJI criteria and had, which is Candida species in 2 or more sterile samples, and had clinical signs and symptoms of PJI such as fever, pain, or other inflammatory indicators were included. And we can see here that there's a pointer here, okay, which is the total case of Candida albicans here is in 269 is actually 55.8%, and then followed by parasilosis is actually 29.4%. And looking at the 2023 again, there's also another systemic review that done by the surgeons in Italy. It's actually a total of 63 studies that they found on fungal PJI, and then a total of 372 fungal PJI were retrieved, and then they collected all the case reports, like small series and also cohort study. And then again, like among all the PJIs, it's just to show again that is Candida albicans, and then first, and then followed by parasilosis. And whereas this is a smaller paper, but it's also like no doubt that, you know, it's again Candida albicans was the most prevalent isolated here. And then this is a really relatively small study in Germany, which is only total 29 patients were included, but the data is still the same. So what it mentions in the Dean and Friends paper also mentioned about this polymicrobial infections with bacterial co-infection occurs in half or more than the Candida PJI cases, which complicating the diagnosis and treatment. And I think they observe the main bacteria actually co-infection with Staph aureus, which is 20.4%, and also coagulative negative Staph, which is 34.2%, and also the Enterobacterialis, which is 23.4%, and last but not least is Enterococcus species, which is 12.6%. And also notably, that is also like 72.5% of patients that had actually received treatment in the last 3 months among all the cases. So looking at other part of epidemiology, primarily Candida PJI actually affects elderly patients, and the comorbidities such as like heart disease and diabetes or patients on immunosuppressant, followed by previous bacterial infections or revision arthroplasty. And hip and knee joints are the most common sites of infections, with some papers actually quote that hips are the one that get more infected than the knee. So this is actually an accepted manuscript in 2000 recently, which is an OFIT, which is the one that on your right. And then actually, I think I'm just trying to put on these two papers to say that IDSA and also OFIT, both like similarity of the background. So whereas the median age is 68. Around 68, which is the one that the manuscript that got accepted. And then like interestingly, and then this paper actually said that's female, whereas like the previous one actually, which is the Deans and Friends, actually mentioned that's male. And but the comorbidities, as you can see here, sorry about this being smaller, but it's mostly relatively, I think it's the same. All right, so how about the outcomes and the prognosis? I think we roughly mentioned. And Candida PJI generally had a poor prognosis with high rates of treatment failures and also like kind of recurrence rate, which is, I think, quoted by multiple papers, but these are the one that I could find. And also overall cure or infection-free survival rates actually varies again from 40% to 73%, depends on the treatment strategies and also Candida species involved. I think the next few presentations were done by my colleagues will discuss about that. So for the infection-free survival, it's significantly lower in the patients infected with Candida albicans compared to non-albicans Candida species, which is, I think, is also explained in our case, which Dongdong will bring us later. And on the right side, again, I just want to show that this is a survival graph that's actually overall, I think, clinical outcome was only 27% in Candida albicans PGI group. I think this was like one of the lowest that the late review that I went through. And in contrast, infection-free survival in patients with non-albicans Candida PGI was 72%. And that's bring me to my last slide here. I think just now also thought to mention about the biofilm of the Candida species on the prosthetic surfaces actually contributes to the treatment challenges and also high morbidities. And last but not least, mentioned in also this Dean's paper that actually old age, such as more than 70 years old, and also treatment with debridement and implant retention, which is DAIR, are associated with higher failure rate, which is whereas like 1 or 2 stage implant exchanges show better outcome. And also I want to mention from the univariate and also the multivariate analysis, presence of Candida parasitic actually show that it's kind of have a favorable outcome, which is, as you can see, the p-value here is significant. Okay, I'll stop share here. Thank you.
I just have one question, Pei Hua, before we move on. You pointed out that Candida infections tended to occur in people with previously treated PJIs. Is it? So is it a super infection? Is it secondary to previous use of antibiotics?
So I find like, you know, like the Deans and Friends paper, they didn't really mention about it. But I find it interesting is that they actually noted that the patients who has Candida PGI actually co-infection with the bacteria and was also pre-treated before. So whether the Candida come after or the Candida happens simultaneously, I think I prefer to say like it's the former one. Maybe after treatment, there's Candida, then you finally decided to treat the Candida. I mean, based on the data that they mentioned here.
Okay. And maybe that may explain why the parasitosis infected people did a bit better, because parasitosis comes from the skin, right? So it might well be that one could surmise that the parasitosis infections were primary infections, whereas the others were secondary. I mean, I don't know. I suppose the paper didn't provide enough granularity on these aspects. Eddie or Atul, you have anything to say on this matter?
Nothing apart from the fact that it was really convenient for the CID paper to come out recently and give us that wonderful kind of summary of epidemiology. So it's been really helpful for discussion, I think.
I think nothing to add. Like, I mean, it is well summarized about the Candida PGI.
Okay, thank you. So let's move on with the lit review. The recommended approaches to antifungal treatment strategies against Candida PJI. Benjamin Chung, please.
Hi, so yes, thanks. So this will be a brief overview of Candida as well as, I suppose, fungal prosthetic joint infections. So we are quite familiar with, as ID physicians, about the treatment strategies that are employed in prosthetic joint infections. The most preferred and common approach is a combination of surgical and medical treatment. And the medical treatment comprises systemic and as well as at times local delivery of antimicrobials. And in some cases, we have to manage it with antibiotics alone, or in other cases, perhaps even more morbid surgery is done. Fortunately, these are done much less commonly now. So in the situation of a fungal PGI, these strategies essentially remain the same, with the antibiotics merely being replaced by antifungals. However, the consideration, the approach in deciding the exact treatment strategy will definitely differ a lot as compared to a bacterial PGI. So this is a pictorial overview of surgical approaches in prosthetic joint infections that we are, again, very familiar with, from debridement and retention of the prostheses to 1-stage and 2-stage exchange. A three-stage exchange is much less commonly employed, but this I will touch on this a little bit later. And yet, even in our familiarity with these kind of protocols, actually, there are many, many questions that remain somewhat controversial or unanswered, especially in the context of a fungal PJI, such as what is the exact best surgical strategy to be employed? How long between explantation and implantation? Are there specific preferred antifungals? Is giving more than one better than a monotherapy of antifungal? Is there a role for local antifungals? And is there a specific or optimal duration, if any, of antifungals after reimplantation? So the logic that underpin the rationale of a two-stage revision or for a fungal or candida PJI are as follows. Firstly, these candida prostatic joint infections are usually chronic. They do form biofilms, as what has been discussed previously. And therefore, the debridement of infected tissue, hardware removal, will reduce the fungal burden as well as the biofilm. And together with systemic antifungal therapy, therefore, the aim is to achieve eradication of infection. And then finally, the second stage, where reimplantation occurs, will allow for recovery and preservation of function for the patient. So therefore, as what the panelists has described in their opinions about how to manage this case, a two-stage revision is a widely accepted strategy for candida and fungal prostatic joint infections. So in this analysis of 119 cases of fungal PJI, of which 88% were candida, the stage revision was the most common surgical strategy. And actually, a two-stage revision gave a success rate of 85%. And this is significantly different from just merely debridement and retention of the device, which gave a success rate of 18%. One-stage exchange was lower with 50%, but I wouldn't read too much into this because the total number of cases was only 2. In a more recent review of 289 cases of fungal PJI, again, of which the large majority were candida species, again, the most common management strategy was a two-stage with a reported success rate of 79%. And consistent with the two previous articles, the recurrence rate of 20 to 25% may be expected and may be quoted when we advise a patient about the potential outcomes of a two-stage exchange. But if you look further into the literature, actually the reported success rates can range very, very widely. And this paper, this systemic review, actually they found that the success rates could range very widely from anywhere from 50% to 100%. And this is not surprising actually, because we would expect that in each case there will be variations in host, the clinical infection in terms of the severity, whether there's bacterial co-infection, the treatment that was employed in terms of the antifungal choice, the duration, and whether there is or there isn't a use of antimicrobial impregnated spaces. So essentially, although a two-stage exchange is employed, actually the various nitty-gritty details of the treatment itself and what's done can differ very, very widely. But what is that we are quite sure of is that debridement and retention of device is in general not a good idea. So this first paper, again by actually the same paper by Kuiper, we already mentioned about its inferior success rates of 18% as compared to a two-stage exchange. And in Dean's paper that we have been quoting multiple times, this prospective multi-center retrospective study of 269 cases, the treatment failure was associated with age as well as the use of debridement and retention of device. Right, so the cure rates that were found here was about 47%, as compared to almost 70% for the single stage and the two-stage exchange. So this paper, interestingly, did not find a difference between a one-stage and a two-stage exchange strategy, which then brings us to the one-stage exchange strategy. Is this a viable option? So a systemic review that was quite recent compiled 16 case series as well as 6 comparative studies, no RCTs, and it comprised 962 patients of hip as well as hip and knee joint prosthetic joint infections. And the overall recurrence rates were anywhere from 0 to 18% with a minimum follow-up of 2 years. And the lowest recurrence rates in these cases happened in patients who are immunocompetent, whose bone and soft tissue defects were not as severe. Of course, the large majority of the cases of these 900 over cases were mainly bacterial. Now, if you look at one-stage exchange that is done in the context of a fungal PGI, so these are some papers that have reported its outcomes. And as expected, the numbers are not high, right? So, but in general, actually, the outcomes that they report do look promising. Of course, bearing in mind the issue of potential publication bias. So, and even as we expect, although all the cases again employ one-stage exchange, there are still quite a bit of variations in how they manage the patient. For example, in this very first case by Salmon, they did a total of 48 hours of joint irrigation with amphotericin B. And this paper by G, after implantation of the new device, the patients had actually every other day intra-articular direct injection of fluconazole. And this happened for a mean of almost up to 3 weeks post-operatively. So indeed, there is a lot of variation in management. And in this other paper by Jenny, the second last paper, it describes an outcome that is not unfamiliar to us. So these are outcomes where PGI was diagnosed only post-operatively. So I'm sure we have had situations where orthopedic surgeons revised the knee joint or hip joint for what was perceived as an aseptic loosening, only then for intra-op findings or intra-op cultures to return as positive for fungus. And eventually, and this inadvertently becomes one-stage exchange treatment for this fungal PGI. And Jenny used this rationale to justify the use of dual antifungal cover. And the last paper, again, the multiply quoted Dean's paper of the 269 cases, again, just to reiterate that the one-stage exchange was found to have a cure rate of 67%. Going on into antifungal treatment, away from the surgical part of things, again, duration can vary quite a bit. So post-explantation duration can vary anywhere from 6 weeks to more than 3 months. Antifungal regimens can vary from monotherapy to a combination of usually dual therapy or a mixture of both. And after implantation of the new device, again, antifungal duration can actually vary all the way from 0 to more than 3 months. So actually, in Dean's paper, although there are a lot of these variations of duration, the mean duration in general is 3 months of antifungals. Interestingly, the duration of antifungal coverage did not actually influence treatment success. And perhaps this is because, especially so because patients who had the one-stage or two-stage exchange, most of the biofilm and the fungal burden were already removed. There are again varying rates of combination antifungals during the antifungal treatment course, again with no influence on outcomes. Again, harkening back to the rationale that hopefully most of the fungal burden as well as biofilms were already removed by then. But can we actually get away with even shorter, well-defined shorter course? So in this very, very small paper by Agnostakos, it describes 7 cases, of which 6 were Candida species, and they employed 6 weeks of systemic antifungals, and they use antibiotic, not antifungal impregnated spacer. And their criteria for reimplantation was actually quite strict. They only proceeded after 2 consecutive normal CRP readings. And during the reimplantation surgery, a frozen section was done, and implantation was only performed if the frozen section did not identify organisms. And perhaps because of this somewhat strict criteria, they were brave enough to not give any antifungals post-op. And at the median follow-up of about 28 months, there were no recurrences. Just one slide to touch a little bit about the other methods, such as a girdle stone, joint fusion, arthrodesis, amputation, or antifungals alone. These are generally associated with poor outcomes and wouldn't be our first port of call. And it sacrifices joint mobility and therefore increases mobility, except for the strategy of antifungal alone. And it is also likely influenced by the underlying reasons why these more morbid suboptimal choices were chosen, such as perhaps the host wasn't was a poor host, or the severity of the soft tissue or the bone damage was just too severe. Now, just one slide to touch about three-stage exchange. Though this is a less commonly employed approach, this merely means that there's an addition of a second exchange of spacer in between. Now, this three-stage revision strategy was actually examined by Becker and to see its utility in fungal periprosthetic joint infections. They compiled 18 cases. All were candidate species except for one case. And in this case, they had 39% of those cases had a bacterial co-infection. There are some rules that they put up in their protocol was that there was a strict 6-week interval between explantation and reimplantation. There was no antifungal holiday, meaning that antifungal drugs were given throughout. They did not do a pre-implantation joint aspirate culture. So essentially, they just put in the new joint after 6 weeks. And their antifungal duration was very, very prolonged, up to 6 months. And with a mean follow-up of almost 3 years, 16 of the cases were actually found to be okay, doing well. So therefore, leading to a success rate of about almost 89%. So my final slide. So perhaps my mental model when deciding treatment strategies of candida and fungal PJI. Firstly, we need to take stock of the case itself by considering the patient factors, surgical factors, as well as the exact fungus of in question. And then after taking stock of that, then decide about what would be the recommended surgical approach. Although we only have a partial say in this, of course, the big decision will come from our surgeons. But mainly, as we now know, debridement and retention of the device is not recommended, and as well as not doing any surgery at all and just giving antifungals alone. These are not good ideas unless there are extenuating circumstances. Now, on the other end of the spectrum, a more morbid kind of surgery such as amputation, arthrodesis, or girdle stone is again also not the first thing that we should be thinking of unless in very specific circumstances. In general, a two-stage exchange would be the most acceptable approach with relatively good success rates, although it can vary in the literature depending on and it will really depend on each case. Now, a single-stage exchange is actually potentially a viable strategy, but I would say that we really need to select these patients carefully. And perhaps considering for a single stage, perhaps in patients with also very, very high anesthetic risk, for example. Three-stage exchange is not commonly employed and certainly not a very established treatment yet for fungal PJIs. And so I would probably reserve that for very difficult to treat cases or multiply relapse cases. And moving on to antifungals, the choice would be governed by the biofilm activity of the antifungal, as well as the susceptibility pattern of the antifungals. So in terms of monotherapy versus dual, again, it would be governed by the ST pattern that we have of that particular fungus, and whether there is a prosthesis that is retained or you have done a single stage. Perhaps there could be consideration for doing dual. Antifungal local therapy will be discussed later. Duration in general is prolonged. ITSA recommends not only just prosthetic removal, but also antifungals for at least 3 months. There should be a minimum of 6 weeks in between implantation and in between explantation and implantation. Now, whether we dare to stop antifungals altogether after the new prosthesis is implanted, as what Arnold Sarkos did, I would say that that is not the standard of practice at this point in time, unless our case has very, very objective measures of absolutely no residual infection after treatment. Thanks.
Okay, thank you, Ben. That was excellent. I have a question for the panelists. I'm quite impressed by how imaginative the orthopedic surgeons are. I know all the varieties of adjunctive therapies that they tried. I think Ben went through some of the intra-articular fluconazole and other such things, 48 hours of irrigation with amphotericin. Would you advise, condone, accept, encourage? Maybe Abby first.
Well, I guess the first comment is I'm not really sure what the benefit of the 3-stage would be over and above a 2-stage. It doesn't really make a lot of logistic sense to me and just gives another procedure to the patient. But nonetheless, in response to your question, I guess I think it may be discussed a little bit later on about some of the methods like spaces and things like that. But as far as irrigation and that, we definitely don't support that practice. Not really sure if it makes a lot of sense to do that. Perhaps spaces with elution may make sense, but not just washing the joint with antifungals. I worry about that.
Thank you. Atul?
Yeah, so I'm also not sure about like how the local therapy is going to work, because we do not have any understanding about the pharmacokinetics of the drug that we are going to use as an irrigation, or when we are putting it as a part of implant or with some beads or something like this. So we do not know the concentration that the drug is going to achieve and what will be the area under the curve, how long they are going to maintain a good level. So when all these important informations are lacking, but I do agree that most of the surgeons, even in India also, they are fond of, trying all these novel things like irrigations, local applications. So we have seen that when the patient has skin and soft tissue mucormycosis, the surgeons used to put the gauze which was soaked into the amphotericin B, and the dressing was done, and apart from the systemic therapy. So we do not know like how this drug is going to act, but it's there like with the surgeon's mind.
Thank you. Yeah, Ben, the 3-stage exchange is very interesting. Like Abby, I don't know the point. Did they say whether the culture was positive when they just replaced the spacer? That's the middle procedure, isn't it?
No, their so-called rules was that they don't do joint aspirate for culture. Yeah.
Okay, so let's go back to the patient and see what happened to her. So let's go back to Tong Tong.
Okay.
Tong Tong, are you muted? Just you
Yes.
may start.
Yeah, can you hear me? Yeah. So back to the story of this patient. So actually, it was treated as left knee candida parasitic PJI, but have a lot of discussion with the family. The family is not very keen for 2-stage exchange at that time. That was in 2018. So at last the patient did left knee azotomy washout and alignment exchanged in May 2018, which is DAIR, which is not super ideal at that time. So this is intraop finding at that time, no PAP, but have some hemocolon root thing. There are unhealthy tissue around the hinge pin and the synovitis thing. And you can see that multiple tissue culture was bench. At that time, all the tissue grew candida parasitic, though there's some just light growth at that time. she was so at that time she was reviewed by infectious disease specialist. At that time started because fluconazole NIC at that time was still quite low. So actually was started fluconazole 400 mg OM and then was switched to fluconazole 200 mg OM about 1 year later. So plan at that time for lifelong suppression. So this was what happened. 2004 August at that time the patient had left knee TKR operation done. About 14 years later had accepted loosening, which counted at that time O negative. So about 2 months after the left knee revision TKR, got some swelling, was treated at the site. But 4 months later, noted to have Candida parasilosis PJI. This is the NIC at that time, and the strategy at that time was given was DAIR after discussion with the family. So the patient was long-term fluconazole suppression. But of course, story will not end at that time. So about 5 years later,
we lost you, Tong Tong. Yes, I think Tong Tong is frozen. Maybe we give him a little bit of time to. And Pei Hua or Ben. Oh, okay. Maybe I'll continue the story. Maybe Pei Hua or Ben can try to contact. Oh, okay. Maybe he'll rejoin. But basically, there's going to be this recurrence 5 years later. I do think we need him to come back to tell us the story, although I could. Tong back on screen, or Ben, you want to share slide, and then we can take. We can.
Hello, sorry, I'm back.
Okay. Sorry, we lost you for a while. Okay, please carry on, Tong Tong.
Yeah, sorry. Actually, did you hear this part? Sorry.
No, please start from here. Yes, start from this slide.
Okay, so this is what happened 5 years later. So the patient was on fluconazole 200 mg OM on long-term suppression. But 5 years later, the patient presented with new worsening left knee pain for 4 months. This time, the pain is quite bad, affect ambulation. That was about the September 2023. But I mean, she was seen by some other hospital doctor at that time, was discharged with continuation of fluconazole. But there was a CT scan at that time was done, which already shows some osteoplasty with loosening of distal tibial stem and compromise of the adjacent lateral cortex. And overall, so she was about a few days after that, she was admitted to Dendosing Hospital for second opinion of left knee swelling. Examination showed 4 by 4 cm swelling over the distal part of the left knee. The impression was left knee chronic PJI that was quite used. So the decision was not for aspiration, just go for the second stage exchanges after discussion with the family. So this is the first stage, the first revision, first stage of this 2-stage strategy, which was done on 15th of September. So operation was done, which showed large amount of orange fluids within the left knee, and tissue were quite unhealthy. And tibial components show the slip and stem loose. And there are multiple pockets of infection with soft tissue and of knee and intramuscular. And the distal part of the knee also found destroyed from chronic effective effusion. So she was started into a fungin peri-operation. And there are there were total 500 mg of amphotericin and 2.5 gram vancomycin was used for in cement spacer. So this is the culture again. So this is the second time, which at this moment, the patient was already given 5 years of the fluconazole suppression. But this time again, the culture group Candida parasilosis. So the fluconazole MIC already this time increased from 0.5 to 2. This time echinocandin MIC is 1. So this leads to the second panel discussion question. So this time, after we see the MIC of fluconazole and antifungal, what will you use? And at this moment, and also, what do you think is the role of antifungal impregnated cement? Thank you.
So thanks, Tong Tong. So now the implant has been removed, right?
Yes.
Because this time the plan is to do a 2-stage.
Yes.
Okay, so implant has been removed, but the Candida MICs have gone up to both anidulafungin and fluconazole. So yes, Abby.
Yes, unfortunately, we were proven right here. The DARE strategy didn't work, but so I think I'd probably be more inclined to use the anidulafungin at this point, just because it does have a degree of lower MIC that is broken through the fluconazole. The MIC has increased significantly for that. Obviously, logistics of delivering that are more challenging than fluconazole, and would have to be probably hospital in the home or some other ambulatory setting to deliver that. And then I guess you could say that, how long do you go for IVs with anidulafungin? 6 weeks is a long time, but you could argue for that. And then perhaps the duration of overall antibiotics before you go for the second stage, as discussed with Din et al., I would probably err on the side of 3 months for this lady, and so probably would go to fluconazole after that, maybe, because I think beyond that it's a very long time to be on IVs. So that would be my thought, would be probably 6 weeks of anidula and then go to decent dosing of fluconazole. I think there was a question about spacer impregnation, and I don't generally endorse that, but I know it is a common practice. I don't think we know enough about its benefits to really recommend it.
Thanks, Abby. I think there'll be a discussion. There'll be a literature review on the spacer. Atul?
Yeah, so clearly there is a disease progression on long-term fluconazole suppressive therapy. So patient has, clinically, the infection was there, the pus pockets, unhealthy tissues and everything was there, and patient was on chronic suppressive therapy. And we know that the MIC for fungus or the bacteria into the biofilm is several fold higher than the planktonic forms of organisms. And probably patient has been exposed to the fluconazole for a long term, and this planktonic form, and because of this exposure, the Candida parasilosis might have emerged or developed resistance to the fluconazole as well as the other antifungal. So this is a very likely possibility over here. Now, good thing is that now patient is going for a 2-stage surgery, and the infected area is removed and the debridement is also done. So once we do a very good source control, like the one of the most important tasks for the management of fungal infection is, I think, that we have done. The source is removed and the unhealthy tissue and other thing is also being taken care of. So now, again, like parasilosis, and still there is probably the elements of some osteomyelitis or the bone infections, and the surrounding soft tissue is also involved because of the long-term the Candida parasilosis, which was there since last more than 5 years. So I think here, and still the anidulafungin has a decent the MIC. So I think I'll agree with the Abby that I'm going to use echinocandins here. So either anidulafungin or mica or the caspofungin. And mica has a little advantage in terms of not only the MIC, but in presence of serum, the PKPD parameters of mica is greatly improved, at the PKPD parameters. So I think, mica probably might have superior edge over here, because in view of the chronic infective conditions into the bone and joints. So I'll give the echinocandins for at least 6 weeks. and we'll try to reassess before I switch back to the fluconazole, and I'll make sure that I'm going to maintain fluconazole level, local level. I mean, though it is very difficult to, look into the pharmacokinetics, but we know the penetration is good enough, and try to maintain the AUC MIC more than 100 here when I'm using fluconazole. So try to give higher dose of fluconazole, try to achieve, because here the fluconazole MIC is 2, right? So I think 200 milligram dose would give you 100 the AUC MIC for fluconazole, because the pharmacokinetics parameters are straightforward for fluconazole. The dose is the AUC. So the AUC MIC of 100 is 200 upon 2 is 100. So I think 200 dose is good enough. But here, like, because the candida has emerged resistance, I'll be on a little safer side and use higher dose of the fluconazole to treat this condition as a chronic suppressive therapy.
Yeah, thanks. Very good thoughts, Abby and Atul. I'm similarly conflicted. But Atul, how are you going to get this AUC of MIC? People don't do TDM for fluconazole.
Yeah, so that's a good question. So for all the clinicians, like, I think fluconazole, I mean, generally we do not require TDM, right? So the dose of fluconazole that you are going to give to your patient is AUC. So rather than looking at the therapeutic drug or the trough monitoring, if I'm using 600 milligram of fluconazole, then the AUC for fluconazole for my patient is 600. If I'm using 800, it is 800. So it is pretty straightforward. So, and when we know the isolate and when we know the MIC for fluconazole, so if I'm using 800 milligrams of fluconazole, MIC is 2 or MIC is 4, then 800 divided by 4 is my the AUC MIC.
Okay, I suppose that's a guesstimate. What was I going to ask? Okay,
but
I think
this does not apply for the other antifungals. For voriconazole, you cannot use the dose as a prediction for AUC MIC, right?
And Abby was going to do 3 months before the second stage. What about you?
Yeah, so again, like, I mean, very difficult to monitor the fungal infections in site like prosthetic joint infections, because here, I mean, we cannot use beta-glucan as a surrogate marker that to monitor the success of your antifungal therapy. It's very difficult. So what we are going to monitor is the inflammatory markers like CRP and the ESR. So we generally monitor our patients on antifungal therapy, and we generally check like whether the CRP is steadily improving and the ESR is going down. So I think, and with these surrogate markers, inflammatory markers, I'm going to monitor, and not, I mean, for 6 weeks. It depends on like how, I mean, early I can reduces the local inflammation or the systemic inflammation by antifungal. So generally 6 weeks of the intravenous casifungin followed by high dose fluconazole suppressive therapy. And if my parameters remain steady for more than 6 to 8 weeks, like CRP and the ESR comes to the baseline, then at 3 months, I think this is a good time to go for a second revision.
Thank you.
Yes, and Ben Hock, sorry if I may. I think, I mean, this is definitely on the upper end of tricky. It sounded like there was pus in the muscle, and you know the patella tendon was where the bone was near the patella tendon was problematic. So I agree with Atul that you know that using the markers and things would be really helpful too, and probably a little bit longer than 3. But you know that would be my ballpark minimum, and then using the markers and the clinical response as well.
Yeah. I think we definitely need some measure, something to tell us that we're on the right track, and that it's, you know, at some point the surgeon will ask us if it's okay to put the second implant in. Does any of you or does anyone think we should stop if the CRP is good and then check a culture before we implant? Or should we just decide that it will be 3 months, 2 or 3 normal good CRP readings, and then go ahead?
I think it's not bad idea to have the cultures from the local area when we are going for a second revision when we are opening a joint. But I think, in my practice or with our orthopedic team, like we generally do not get the cultures. We do not do aspiration before we go for a second revision. We just rely mainly on the inflammatory markers. But during operation, like we do collect just to, make sure that, the infection was present or it was absent.
Okay. Abby?
Yeah, I agree. I agree with that too. We generally don't do a pre-implantation sampling, but certainly at the procedure, there'd be description of the joint and multiple samplings, and you can use that in retrospect to work out how worried and how long you might go for with antifungals later.
Yeah, I think the IDSA guide, it's not specific for fungal infections, but they didn't recommend it routinely, but in some cases one might want to resort to that if there's been previous failures or if you really wanted to be very sure. It actually, Tong Tong is very interesting. The patient started at 76, but 5 years later she's 81, and now she's going for a 2-stage surgery. Anyway, yeah, let's go back to the case then. Tong Tong? Are you there?
Yes, I'm here. Yeah, I just want to share the slide. Yeah. Yeah. So actually, she was given 6 weeks of and as what just now discussed also. So actually, she was given 6 weeks of antifungal because of breakthrough fluconazole Candida parasitic infection. But unfortunately, during these 6 weeks of IV antifungal, she has some complication of line infection with Klebsiella pneumonia, which needs another IV antibiotics. And at last, she was switched to a bit higher dose of fluconazole, 400 mg on since 28th of October, while waiting for the second stage revision. So, as a discussion, she was continued fluconazole for quite well. And at the same time, we also examined the patient quite frequently, and which did not show any erythema, no sinus. It just had very minimal localized infusion over the lateral aspect. So we also monitor the ESR very frequently. From the initial number, about the CRP initially was 21. In between, the patient may have some gout events at the same time. But at last we wait till the ESR dropped to 5 and the CRP dropped to 2.9. So at that time, around 2024 March, then we decide, okay, maybe we can consider to stop the fluconazole. Then we may need to consider the second stage. So this is the timeline for this patient. So around March 2024, fluconazole was stopped. At that time, actually, the patient was given antifungal and the fluconazole for about 6 months. And at that time, the ESR is 5 and the CR is 9 of 6 months of the. I think this is the last question, which part of it we already have discussed. Is that how soon would you advise for the second stage? And will you stop the antifungal before the arch? Will you do the joint aspiration before the second stage, or would you stop antifungal after second stage?
Yes, I think these questions have been answered, Tong.
Yeah. So so maybe we just talk about the timeline of this patient. So about 1 month later, after stopping the fluconazole, she was admitted for. We are just very worried. So we discussed with surgeon. She was readmitted for left knee joint aspiration in OT. At that time, we repeated multiple aspirates, and at this moment, the synovial fluids showed the neutrophil 8%, but culture, gram state, everything is negative. That is about 1 month after we stopped the antifungals. And 1 month later, she was admitted for second stage left knee TKR. This time, the operation finding actually does not really show any signs of infection. And overall, seems everything is quite under control. And at the same time, she was given another 1 gram of amphotericin powder into the joint and was restarted fluconazole for a while till at last, when we see the patient in the clinic, the patient is really quite well, and the ESR, CRP all flat. Then around September at that time, another 2 to 3 months, then we decide, and we just continue to monitor and we stop the fluconazole. So this is where the patient now. So the patient now is well. From the restarting fluconazole till now is at least about 7 to 8 months. There is no suggestion of the wound discharge or sinus or dehiscence, and the patient able to flat and degree. So this is the whole timeline. In 2004 got TKR. In 2018 got TKI revision. Then 2018 May did the DAIR with fluconazole, but unfortunately 5 years later got recurrence and was switched to two-stage strategy. And till 2024, repeat the knee aspiration, and in May, had the second stage done. Around September, stop all the antifungals, and the patient is doing well till now. Yeah, so I think that's what I have for this patient.
Thank you.
I think the last question. Yeah.
Congratulations. So the patient has done very well. You are doing the lit review next, right?
Yes. Yes, so I will talk a bit about the Candida parasilosis, especially about the echinocandin versus azoles. And later the James will talk about the local antifungal or local antibacterial agents, the evidence. Yeah, just wait a minute.
Yeah. Please proceed.
Yeah. Yeah. So I mean, in this case, actually, it's because the pathogen is Candida parasilosis. So actually, we have a lot of concern about whether it is okay to use echinocandin because of the intrinsic FSK mutation, whether we are okay to use fluconazole because of fluconazole MIC increasing in this case. So we just did some review about the Candida parasilosis. So, I mean, in different countries, actually, Candida parasilosis, the epidemiology is a bit different. But overall, it is second to fourth most common species causative of Candida in the world, and the mortality rate is not low. So, if you see here, the Asian country, the Candida parasilosis, the proportion of Candida parasilosis in invasive Candida infection is about 10 to 20%. So this was the classical landmark study in 2007, and that's the time that where we think the immunocompromised is not inferior to fluconazole in invasive candidiasis. Instead, maybe even a bit better than in invasive candidiasis, which we can see fluconazole versus immunocompromised, the global successful rate actually immunocompromised is better, and also we can see this Kaplan-Meier curve, which show that immunocompromised has better survival rates. But if you see the subgroup of this population, we see the Candida parasilosis actually not doing so good. So Candida parasilosis, the successful microbiology response is about 69 versus 88 in fluconazole group, and also successful global response, the Candida the immunocompromised is doing a bit worse. But the question is that there are only 26 isolates, and the p-value actually is quite high. So may not be very significant, though there are some signals say that Candida parasilosis may the echinocandin immunocompromised may not be so good. And we also see the Candida parasilosis, the MIC of immunocompromised a bit higher than the other Candida groups. So this is the paper which showed that actually the Candida parasilosis has intrinsically higher MIC or intrinsic reduced susceptibility of this species to echinocandin. the main mechanism is because there are some natural occurring FKS1 mutation in the hotspot 1 gene, which was found to be responsible for the intrinsic reduced susceptibility. This is another paper which showed that because of the amino acid substitution in P650A in the FKS1P from the Candida parasitic, which can explain the reduced susceptibility to echinocandin. So at that time, in 2009, IDSA guideline for the treatment of the Candida parasitic, actually they favored to use fluconazole at that time instead of enidulafungin. But because of the intrinsic higher MIC to the echinocandins and because concern of the intrinsic resistance. So at that time, they also state that for the patient who already initially received echinocandin and clinical improving and the follow-up culture results are negative, maybe we can continue to use of echinocandin, which is reasonable, but that is about 2009. So after 2009, there are some paper, though that not very big study. This is a prospective study which was done in Spain, about 194 episodes of Candida parasitic bacterial bloodstream infection. So which they found whether you the first few days with echinocandin versus the first few days with azole or even combination therapy, actually overall the mortality does not change. And they do the univariate and the multivariate logistic regression analysis. Actually, there's no difference whether you use an echinocandin-based regimen at the beginning or use azole-based regimen or amphotericin B-based regimen. And we can also see clinical failure, persistent BSI, or 32 mortality. There are not much difference. After that, there is another retrospective study which was done, which also showed that actually whether you treat with echinocandin versus you treat with fluconazole for 2 weeks or even longer, there is no mortality difference between patients on echinocandin versus fluconazole. So till 2016, actually there are some guideline changes because though that theoretically there are some difference, there are some concern of the superiority of the fluconazole over the echinocandin. But actually in clinical practice, there are not much difference. And so that's why overall in 2016, overall suggests for whatever Candida species, the echinocandin still recommend as the initial therapy. But for Candida glabrata and the Candida parasitic, maybe you should check the MIC of the echinocandins. And this was just published in 2025, a few months ago in ECMN, ESHAM, and ASHM. So which, though that we admit that for the Candida parasitic and Osteoarticular, they have higher echinocandin MIC because of naturally occurring variant in FXK gene sequences, but clinical response appear to be similar. And overall, the true resistance to echinocandin is considered quite rare in this species complex. So overall, still suggests echinocandin. But at the same time, we also facing another question, another problem is that we seeing more and more fluconazole resistant Candida parasitic. Actually, you can see in some Asian countries, actually the recent rate can even go up to 10 to 30%. And this is the case. This is the paper which was published about 2 weeks ago, which is in US Some Reference Center. They collect about 1,740 Candida parasitic blood isolate. Actually, after COVID period, up 2021, there is an increase of fluconazole resistance from 8 to 20%. And overall, the nicafungin resistance rate is still quite rare, but there are also some signals show that the intermediate susceptibility significant increase, especially after 2021. So whether during the COVID this time something has changed a bit, not very certain. But since this is all occurred after 2021. So the azole mutation is azole resistant. The mechanism is mainly the point mutation in the ERG11 gene. This is another paper which show the dominant mechanism of fluconazole resistance in Candida parasitic is ERG11P substitution. But consider is maybe, I mean, the treatment It's not just because based on the medication, but we also may need to see the penetration. So how about the penetration of candida, penetration of echinocandins, azoles to the bone and to the joint? So this is a paper published in 2014, which showed that actually fluconazole bone penetration will be about 0.33, the synovial flu about 0.8. The voriconazole has very good bone penetration, 5, but synovium penetration is only 0.25. This is another table to show that the penetration of fluconazole. So overall, fluconazole to the synovial fluid maybe about 0.8. Voriconazole not very good, but the bone penetration is good. For the echinocandins, there are not a lot of studies. There are no studies about the caspofungin and micafungin in 2014 at that time. But overall, amidulafungin may be still okay. So this is another paper which was published about 4 or 5 years ago to see about the bone penetration of the azoles, caspofungin, and amphotericin. So azole, as what we see just now, is about 0.33. But actually, if we see the echinocandin, amidulafungin maybe 0.525, but caspofungin actually have quite good bone penetration. And also the amphotericin, actually the bone penetration is not bad, it's more than 5 compared with the azole fluconazole. This is another study to see, I mean, we talk about lots about the biofilm, especially the echinocandin, amphotericin versus fluconazole, because of the biofilm displayed the high resistance of fluconazole. But yeah, so this study just show the caspofungin had very good potential activity against the biofilm and drastically reduce the biofilm diversion. So I think my slide summary is that we think the Candida parasilosis, the fluconazole resistance has been noted globally, but echinocandin, we know that they carry intrinsic resistance polymorphism, which will lead to higher MIC, but clinical response actually generally remains favorable, and most isolates are still susceptible. And whether to use fluconazole echinocandin just for the Candida parasilosis, which is both sensitive, actually there are no clear superiority, which really depending on the penetration, susceptibility profile, and the clinical context. And overall, we think fluconazole still demonstrate acceptable joint penetration. The echinocandin lack robust PK/PD data, but for the bone penetration, caspofungin actually seems quite good. And because of the biofilm active agents, so it is potentially useful in the PJI, especially in the VAIR setting. Yeah, thank you.
Okay, thanks, Tong Tong.
Yeah.
In the interest of time, let's move on to Dr. James Kang, who will talk about the loading antibiotics into bone cement. James, please.
Hi, everyone. Okay, right, for interest of time, so we'll hurry up a little bit. I'm not going to talk too much about history, but pretty much with bone cement has been around for nearly 50 years, believe it or not. And it was initially used in prophylaxis, and over time, it's been introduced as treatment modality for PJI and osteomyelitis. So interestingly, FDA has only approved that for prophylactic use only in 2000. So really, the use of antibiotic bone cement for treatment is kind of non-standard of care. So what is it really? It's polymethyl methacrylate, also known as PMMA. So essentially what we do is we take bone cement and we mix it with antimicrobials, and the hope is if they give it into the joint, it will last a long time at a high concentration and hopefully avoid systemic toxicities. But we will find out whether that's really true. So it's used in primary and subject divisions. And really how it works is take a bag of polymers, antibiotics, mix it with some monomers, and then an exothermic polymerization process happens. And then that's when all the antibiotics get mixed into bone cement. So yes, you use a spatula, but there are other ways of mixing, such as centrifuge and vacuum. There are pros and cons in each type of mixing. So you talk about porosity, strength of cement, and levels of elution of antibiotics, depending on how well you mix it. Then yes, once it forms like a dough and it sort of settles, people sort of mold it into a joint. There are instruments that will help you fashion it into like a stem or like a spacer. So there are many ways to introduce that into a joint. So finally, the antibiotics then elute as a result of surface phenomenon or diffusion via little cracks and pores that are established during the setting phase. And that's how you get local antibiotic penetration in a joint and tissues. So just a picture for some of us who may not be so familiar. In the top row, you're going to see some antibiotic blocks of cement. You can ship it into a joint like a femoral stem. We've got spaces, and these days we have even articulating spaces as well. And the bottom row, you'll see people using beads, bead chains. So the benefit of this is they fill little crevices much better, so you have a lot less dead space. So that while we talk about antibiotic loaded bone cement as something, off the beaten path, but there are actually ISO standards to maintain a certain compressive strength, bending strength, and bending modulus. So as I said, when you introduce antibiotics, while the action of it is antimicrobial, it disrupts the polymerization process. So it actually affects the strength of the cement. So there is kind of like a maximum dose that you could add before it really compromises the mechanical stability. But at the same time, we need to bear in mind that there are systemic toxicities that are associated with high dose of local antibiotic use because it elutes and it can actually go into the serum, especially in situations where there's concomitant systemic antibiotic use. Now, an ideal antibiotic for use in bone cement needs to be, in powder forms because it makes better than liquid, cidal, broad spectrum, synergistic with any other antimicrobials. It elutes well at high concentrations over a long period of time. It's stable because the polymerization process is exothermic, low risk of resistance induction, causing allergy, and of course, doesn't influence much on the mechanical properties of cement. Then, of course, the cement itself, the composition, the surface area, and the porosity also affects the elution process. And these principles that we learn from antibiotics apply for antifungals as well. Now, how does it really work? So just an easy, simple diagram. Phase 1 is when there's this rapid peak in antibiotic concentration in the joint right after implantation. That takes place about within 24 hours. Then in phase 2, there's a rapid drop-off levels, but still at a pretty high level, and that's over a number of days. And then phase 3 is a mystery because it really depends on what sort of antibiotic it is, and they're really not very well established in vitro and in vivo studies to tell us that. Generally, most people agree that it lasts for several days, and some suggest that it may elute antimicrobials for months. So highly variable. So some pictures of commercially available premixed antibiotic-laden bone cements. So the common ones that people use are typically vancomycin and aminoglycosides. Sorry, the words are a bit small, but clearly someone has tried other drug classes, beta-lactams, meropenem, and in this talk, we'll talk a little bit more about antifungals later. Now, what's the evidence really? Now that we know that in vitro findings seem to suggest that it might kind of work, but does it really work? So Yarikov in a NCID paper in 2012 looked at over 20 publications that had follow-ups of more than 24 months after the two-stage arthroplasties for PJI. So of note, there were no RCTs and most studies were uncontrolled. Not all studies reported susceptibilities, and what was interesting was, even though some isolates were resistant to antibiotics placed in the cement, they did well. And that's probably because of systemic antibiotics that was given and or local source control with debridement. So most antibiotic doses had a huge range, anywhere between 0.25 to 4.8 grams for aminoglycosides and vancomycin 1 to 4 grams. So infection eradication rate varies widely, as previously talked about, 46 to 100%, and there was no associations found between reported eradication of infection and doses of antibiotic cement use. So the conclusion from this paper was there was really insufficient evidence to support any particular dosage recommendation. Now, there are some caveats that apply for both antibiotic and antifungal loaded bone cements. There are clearly significant differences in terms of in vivo and in vitro antimicrobial elution from spaces. So much of what we know actually originated from studies that looked at impregnated cement device other than spaces such as this. And since antibiotics elution is really like a surface-dependent phenomenon, it's really hard to compare, size of a hip and a joint spacer, is it articulating or not, different geometry and surface area. So what we know in one model may not apply in other models. And clearly, measurement of antibiotic and antifungal levels are usually taken from a single location, such as a drain in situ in a joint space and then measured over days. Now, that doesn't really account for things like tissue, deep superficial tissue levels. Clearly not going to measure the femoral cavity where the stem is sitting in. We are not going to be able to account for vascular blood supplies or diffusion into the surrounding tissue that affects the diffusion gradients over time. So essentially, in vitro studies do not really account for in vivo bone cement tissue dynamics. So while the clinical benefit is unclear, maybe not a bad idea to put it in, but is there any safety concerns? So the way you think about it is local implications for the systemic. So local, you think about things like mechanical problems like fracture, dislocation of the spacer. It disrupts the anatomy. You might affect the mobility of the patient. Whereas in systemic, you think about drug toxicities like nephrotoxicity or hepatotoxicities, and it really depends on what sort of antibiotics or antimicrobials put in the spacer. So Thomas and colleagues in 2024, in the most comprehensive and up-to-date systematic review of acute kidney injury, looked at 24 studies across many joints, hip and knees, and a combination of both. Majority of them used combination of vancomycin and aminoglycoside, and when specified, post-op IV vanco was always administered. So definitions clearly vary in terms of acute kidney injury. People use things like KDIGO, AKIN, RIFO criteria, even their own criteria of certain increase in serum creatinine. So you already can tell there's some difficulties in comparing studies from one to another. So there are some mean incidence was anywhere between 4 to 27%. Clearly, if there were more joints involved, then the risk goes up. And this is very heterogeneous. Some cohorts had 0 reported nephrotoxicity, which caused a question about underreporting of some sorts. The common theme was patient factors such as underlying chronic kidney disease, low pre-op hemoglobin, blood transfusion requirement probably contributes to some degree of pre-renal acute kidney injury. Of note, that some spacer-related risk factors such as high antibiotic dosage and antibiotic type. However, prognosis-wise, those that developed AKI generally recovered without complications and few required dialysis and all went on to develop chronic kidney disease. So as previously mentioned, those that studied AKI as a primary objective seem to find higher incidence, whereas those that AKI as sort of like secondary outcome don't really find that much. So serious underreporting is in the literature. So despite spacer antibiotic characteristics being most investigated AKI risk factors among these studies, majority reported no significant association with antibiotic type or dose. So as usual, caveats are studies are all retrospective, they had very low level of evidence. So there is some concerns that, since we're going to leave this spacer for many weeks, not months, are there concerns that resistant microbes will survive after the burst release and then be selected for over time? So there is really just conflicting clinical evidence. Some in vitro studies suggest that when you take the spacer out, they may find biofilms. There have been cases where samples where they are culture positive at the time of reimplantation was associated with risk of failure subsequently. But really, we don't really know, and we don't really think there's a strong indication or signal that suggests that use of antibiotic-laden bone cements in prophylaxis or treatment have increased antibiotic resistance. Although that being said, if somebody has had exposure before, if a septic joint recurs, you might want to think about using an alternative class of antibiotics for the time being. Okay, just quickly, antifungal loaded bone cement. No, that's not actually cake. That's actually amphotericin B loaded bone cement. Looks a bit like cake. So what we know from the in vitro studies, we know that polyenes and azoles are good. They tolerate and are active after cement polymerization. There's some mixed data from amphotericin B, but people think that it elutes well, and more so with liposomal amphotericin B than the oxycolic version of it. And for triazoles, the fluconazole and voriconazoles are better studied, partly because they've been available a longer time. Echinocandins are not really well liked, I suppose, because they have a very short duration of elution compared to polyenes and azoles. So really, only a few studies have investigated local elution of antifungal agents in the early post-op periods. Now we're going to go through all of it, but essentially in these studies, all had 2-stage ops, and they found that triazoles and ampho-B generally eluded well in vivo. What they did was they measured levels in the drain that was in the joint, and peak levels tend to occur within a day to 2 post-implantation, and most of them maintain levels at least above MIC over the course of several days. But that's kind of limited because it's probably not ethical to keep a drain for 30 days to study the entire duration of elution. So there were no significant safety concerns that were reported. Now we just go through just 3 systematic reviews, one by Fosserinpas and colleagues in 2022 of fungal hip PGIs, mostly Canada, as we expect success rate was about 64.5%. Gonzalez and friends in 2023, a small number of them had hips and knees that had antifungal spacer use. They found that use of these antifungal spacers was not a significant predictor for recurrence and on multivariate regression analyses. And we have already mentioned that this convenient paper by Gibet et al. In 2025 that just came out of Canada hips and knee PGIs, about 30% of failed and successfully treated hip PGIs used antifungal loaded bone cement. So it was not statistically significant or different, suggesting that antifungal impregnated spacers had no significant impact on outcome. Now, so the characteristics in selection of local impregnation of antifungal bone cement would pretty much follow that of antibiotics. You know, they should be active, they should elute well, and they should be in powder form, things like that. But really, there is a lot lesser literature and evidence out there for antifungals. And clearly reporting is highly variable and often incomplete. So the long and short of it is we don't really know. So the optimal characteristics of antifungal bone cement and safety remains quite fully defined at the moment, and its role remains controversial, if not more so than antibiotic bone cement. Now, in my last slide, what do the guidelines say? Well, the truth is the only consistent thing that's been put forth so far is that we don't really have good data, and we can't really support nor deny the use of antifungal loaded bone cement. Pass time back.
Thank you, James. That was truly comprehensive and very well presented. So that brings all the presentations to a close. I think we have a little bit of time for some discussion. I'll take some of the questions from the Q&A and direct them at our expert panelists. So Kauza from Pakistan is asking, if we do intraoperative samples for cultures, the report will be late. So what's the advantage of doing it? I think you're referring to doing cultures at the time of the second implant, right? Abby, you want to take that?
Yeah, it is a valid point. I guess the testing at the time is more of a confirming success, which is likely to have been the case, I think. I don't think we would go forth for the second stage unless we were quite confident that, you know, based on inflammatory markers and clinical progression, that things were going well. We've had a good duration of therapy. So the sampling is more of an insurance policy, and if in the surprise that we do actually grow it, it would still inform how long we were to give antifungals for, and perhaps, you know, decisions about whether we stop ever. But yeah, it's more that we're confident in success and not the other way around.
Thank you. Atul, you want to say anything to that?
No, I fully agree with Dr. Abby that, I mean, it's just to make sure that everything was good. But the only thing that I would like to add is that, like, most of the time, like, the surgeon will try to get a sample from the suspected area. So if they found that there are some areas which are not healthy, so I think, I mean, that sample probably would add more value to the assessment.
Yes, good. Atul, there was a question on why not caspofungin. I think you were referring to this, right, just now? Maybe you just want to go through that again, or
yeah, sure. So I mean that there is no preference amongst the echinocandins. All three are having a same activity, but there are some theoretical differences. I'm not talking about the drug interactions with the caspofungin and less drug interaction with the others and other things, but the important the antifungal properties. The one important thing that has been well described with the caspofungin is that, like, if you increase the dose of caspofungin in case of endocarditis or in case of some difficult infection, fungal infection, where you would like to increase the dose of your echinocandins, then the eagle effect is very well described with the caspofungin, where there is a paradoxical increase in the growth of the fungus when you increase the dose of caspofungin. So generally we expect that there is a further reduction when you increase the exposure of the caspofungin. So this eagle effect is probably one concern when you aim to use higher dose. And the difference as far as the antifungal activity is concerned with the mica fungin is that the mica has when you treat Candida auris, mica has the lower MIC as compared to the other the other echinocandids. And the another important points for Candida parasilosis with the mica is that whatever the MIC that we measure in vitro with mica fungin, but these PKPD parameters in presence of serum, even you test, even if you add serum in vitro for the mica fungin MIC, you will find the significant improvement into the mica fungin activity. So in presence of serums, the mica fungin activity against the Candida parasilosis is generally the very good. So PKPD parameters are obviously changed. So these are the two small, probably theoretical, but there are some the differences probably we may try to exploit in difficult to treat situations.
Thank you very much. Yeah, there was a question on how irrigation of the joint would help, and I think I don't think it will really help. I think the two expert panelists did allude to that just now. Are there other questions that we haven't answered? If not, I think was there a question about amphotericin powder? It disappeared. Or did I answer it by accident?
It just suggested it was innovative in inverted commas. It's a strange approach. Yeah.
Oh, BD, yeah, would you track either beta-D-glucan or galactomannan? That was a question on that, Abby.
So I well, certainly in Australia we really don't use beta-D-glucan at the moment. It's not widely available, but I'm not aware of good data to suggest that it's that useful in this setting. I'm pretty sure Atul did mention before about BDG not being super useful in this setting.
Atul?
Yeah, so I think the BDG may not be that useful in monitoring the treatment of invasive candidiasis. The reason is that we have a very good the understanding from the BDG kinetics when you are treating a candidemia. So serial BDG, like even when you have a successfully eradicated candida from the bloodstream, the 20% of the patients may have actually rise in the BDG level despite there is a successful clearance of the candidemia. So BDG probably is not a good the biomarker to monitor the invasive candida treatment, because in 20% of the time it may give you the increased value, and you may I think be surprised that probably your treatment is failing. So I think we should try to avoid BDG. And the second point for Candida parasilosis and BDG, generally there are two Candida species where the BDG level is generally very low. One is Candida parasilosis and the second is Candida auris. So these two Candida species, they have lower level of the beta-D-glucan in their cell wall. So you will not get the higher BDG value even though the patient is having Candida auris or the Candida parasilosis candidemia. So these are the few limitations, yeah.
Thank you. That's very erudite. I mean, I don't use BDG. We don't have it in our hospital, so I have no experience with it. But I think we've overshot. And thank you very much to the two expert panelists for all your insights. Thank you also to the presenters. I think it was a very good case, very well chosen, nice long story told. And thank you, of course, to the people who shared with us all the hard work doing the literature review. Just to tell everyone that there's a survey form to complete. So please do that. We want to see how we're doing and how we can do better the next time. There are 2 more this year. We hope to continue running this about 4 times a year. And then we're going to show a QR code because there'll be a replay tomorrow on YouTube. So you can share this with your colleagues, those who didn't manage to come. Okay, thank you very much. And bye-bye, everybody. Have a good evening, rest of the day. Thank you.
Thank you. Thank you. Goodbye. Yeah.